Um, Welcome to the debate. So my name is Shuayb Elkhalifa. I'm one of the consultant immunologists at Cleveland Clinic, Abu Dhabi. So today is the day. Today, my proposition is all patients with cough should have allergy testing. Let's all make allergy and immunology great again. Micah, right? So, where is the changer? Is that the one? Perfect. Okay. So before we start, I want to make sure we're talking about chronic cough. We're not talking about acute cough that lasts less than 3 weeks, which is commonly due to acute viral infections. We're talking about chronic cough that lasts for 2 months, refractory cough that may be associated with hypersensitivity syndrome. So before we start, let's agree about one thing. Cough is due to the hyper-responsiveness of the epithelial barrier. So the question is, what makes our epithelial barriers hyper-responsive? And we have got the answer. There is a lot of triggers and factors that can destroy our epithelial barriers, and there's a lot of factors that protect our epithelial barrier, right? And obviously, we know allergens are the main trigger for the epithelial barrier. You see the allergens there on the top. They cause loads of intracellular cascades and signaling, resulting in one of the two bad cells, our enemies, ILC2, innate lymphoid cells, and Th2, T helper 2 cells. And those 2 cells causing all the problems we have in the upper airway and the lungs, causing the cough, the asthma, all kind of atopies. There are loads of studies supporting the early sensitization to air allergens associated with cough, associated with asthma, with food allergy. This is one of the very elegant studies, multi-center, between Japan and Sweden, and they looked at the over 300 children over time, over 2 years. And what they found very clearly here, you can see the children with asthma have more than 1 allergen. So blue, if you have sensitivity to 1 allergen, green to 2, red to 3, and yellow more than 3. And we can see here clearly, people sensitized to air allergens, they have got a high risk of cough, asthma, and all the causes of atopies. So the question is, why we develop this and how we can prevent this. And I'm going to show you that because I want to convince you we have to do air allergens, right? So we're going back to 1940s, the original studies to look at the causes of allergy, cough, asthma, atopies. And this is one of the very old studies comparing Russian to Finnish, and they live next to each other in the Northern Europe, but they exposed to different socioeconomic status. And what happened is, you can see here, the Finnish in blue, they've got a very high risk of cough, atopies, allergies. Now, the main concept we learned from that, the concept of biodiversity. And that's one of the main reasons people develop allergies, cough, asthma, atopy. And that's to start with our microbiota, with our lifestyle. We lost our microbiota, and that's why we lost the biodiversity, and that's why we're developing the cough. We become too clean. And that's resulted in all the advances we have, all the problems we have with allergies. We become too clean. What we need to become slightly exposed to our old friends. And I've got two short kind of comments on two major studies to explain what I mean by the old friends. And this is our hygiene hypothesis. So all the microbes that's available in the farms, in these camels, horses, cows, these are the microbes we need. And this is one of the very old studies as well from 2000, looking at children in the rural areas of Austria, Germany, and Switzerland. And you can see here the evidence of asthma in them, really almost none. And one of the very well-established study on Amish tribes and groups across the North America, that's most of you have already seen this study, but that's a classical example of the loss or gain of biodiversity. So we need to go back to our old friends. We need to be less clean for our children to prevent allergy. And because we become too clean, we cough a lot. And that's why we need to have allergy testing. Now, by this, you've got two major groups. You've got the group with the Western lifestyle, exposure to aero allergens, loss of cough, loss of asthma, loss of allergic rhinitis. And you've got here the group that's exposed to the farm, to microbiota, where they have got less allergy, less cough. So what we need now, we need to actually test IgE for all aero allergens. And we know the increase of these aero allergens is all because of our Western lifestyle, all because of what we did. So what we do in the allergy clinic then for chronic cough, we're going to take a detailed history for patients coming with a chronic cough to figure out the atopies, the exposure to farms, and how if they have any sedentary lifestyle or Western lifestyle. And then we need to do skin testing for them. And if the skin testing did not show that, then we might need to do aero allergen. And aero allergen, you have got different types of aero allergens or IgE component testing. And obviously, this is just to show you, if you come to me 15, 20 years ago, and I'm testing peanut allergy, I would just say the IgE is positive, you're allergic. But now we know there's different type of levels. We know the carbohydrate determinant could be positive in many patients that have the sensitivity but not allergic. But when you come to the one in the middle here, the profiling and PR10, they've got less risk of developing allergies or severe anaphylaxis. That's mainly with food allergy. I'm trying to confuse you here. Right. So the pan-allergen, which have got the profiling on the top and the PET-V1, those are the allergens we see in pollens. And a lot of tests can come positive with this. We have to interpret them with cautious. And we have to consult an allergist or immunologist to get that sorted, right? So, as an immunologist or allergist, have got a lot of way I can intervene and prevent cough. I can give immunotherapy for patients who are allergic to aero allergens. And there are a lot of studies on mild asthma with allergy to house dust mite and how that's effective. I can induce the T regulatory cells, and that's what I want to do. So I can prevent asthma and cough. And I can give those patients prebiotics or biobiotics. So I think by now, you all agree with me, microbes, our friends, our old friends, and life as Western lifestyle, sedentary lifestyle is the main problem. And currently, we're all living that style. So we all must have allergies. So we all need to do a skin prick testing. So let's come together and make allergy and immunology great again. Yes?
So I think from the question the chair asked at the beginning, I've already won this debate. So I will not be able to match the enthusiasm and the hand actions of Dr. Shuayb. So I propose that most patients with chronic cough do not need allergy testing. Why? Because chronic cough is a chronic refractory cough is a disorder of dysfunctional airway sensory nerves and their central processing, as opposed to an allergic epithelial process. If we take a step back and look at the cough reflex is a protective mechanism. It's there to prevent aspiration and enhance airway clearance and reduce the problem of respiratory disease from allergens. However, when cough becomes prolonged, there is some remodeling and some sensitization of the central nervous system, which heightens the cough reflex, and this leads to the chronic cough. When we talk about the cough reflex, there's a type of true cough reflex, which is a mechanosensory in nature. And this is the true reflex, which is very similar to other spinal reflexes and involves the myelinated pathways. However, the more common reason for chronic cough is this urge to cough, the tickle in the throat the patients describe, the chemosensory cough, which involves unmyelinated C fibers, which are very similar to the pathways involved in chronic pain, irritable bowel syndrome, and these other chronic conditions. And if we look at the cough reflex in detail, we can see that, of course, there are a lot of receptors, ion channels involved in the stimulation and activation of airways. However, the vagus nerve plays a big role, and these action potentials are generated to the brainstem and to higher brain centers, which, of course, can lead to us or to patients being able to suppress their cough. And there is this very nice study that showed that patients with chronic cough essentially are unable to suppress their cough, and they cough more. So this study suggests that there is a big role for the central nervous system in patients with chronic cough. Because in this study, you can see that patients with chronic cough, when they were told to suppress their cough with capsaicin activation, that they were not able to suppress their cough. And in healthy controls, you can see they're able to suppress their cough much, much better. So the burden of chronic cough from our patients that we see in the clinic on a regular basis, we know it's very debilitating and very severe, and it affects every facet of their life. From the clinic, we know that most patients with chronic cough also suffer with anxiety, with depression, and a lot of studies show that up to 70% of patients with chronic cough can have symptoms of anxiety and depression. It does affect their quality of life, especially in this era of COVID, where cough has become the new Allahu Akbar, that patients with cough are scared to go outside. You know, they experience social isolation. In females who have chronic cough, and this is the biggest population we see, patients with chronic unexplained cough, females from the age of 50 to 70, they can have urinary incontinence, which also leads to more social isolation. Patients with chronic cough, we know, have increased healthcare utilization. We know there's absenteeism from work, which leads to significant economic burden for these patients. What's the burden? What's the prevalence of chronic cough? We don't really have very good data for our region. However, this was a very nice systemic review and meta-analysis which was done, which shows that the prevalence of chronic cough around the world is around 10%. Yeah, it's more common in Europe and Australia. However, the differences in regions is more to do with the availability of data rather than intrinsic differences in genetics or biology. When we're approaching a patient with chronic cough, we are very used to the usual algorithm of trying to define specific conditions that lead to cough. So we know the big causes of cough in our clinical practice include asthma, some sort of reflux, upper airway disease, including postnasal drip, and some drugs like ACE inhibitors. However, what I propose is that we take a more holistic approach to treating patients with chronic cough and trying to find some modifiable and treatable risk factors. For example, you can see if we have a patient with reflux, we might be able to treat the reflux very well, but at the same time, if they have obstructive sleep apnea, which can cause upper airway inflammation and make the GERD worse, by treating the reflux alone, we'll not be able to solve this. So we have to take a more holistic approach and try and look at the patient as a whole and see which treatable traits or which modifiable factors they have so that we can offer better treatment. Okay. So in our approach to chronic cough patients, you can see there will be a very little role for allergy testing. We rely mainly on the history, physical examination, and trying to elucidate any risk factors that can lead to the cough. Simple clinic investigations such as chest radiology, spirometry with reversible testing, and Excel nitric oxide will be able to give us the diagnosis in majority of the patients. And if we're able to find the diagnosis, we can start the appropriate treatment. Once we start the appropriate treatment, the cough will resolve. If the cough does not resolve and the patient comes back, then we need to do some further testing. For example, high-resolution CT scan, because IPF can be very common and it can be missed in patients with chronic cough. However, if the patient you feel that has had adequate treatment for all the treatable and modifiable risk factors, then this patient will become a patient with refractory chronic cough. On the other side, if you do all the extensive investigations and you cannot find a cause and the patient is responding to any sort of treatment, we can consider this patient to have unexplained chronic cough. Just a few words about refractory chronic cough. This is cough that persists despite identifying all of the risk factors that are modifiable and giving adequate treatment. And unexplained refractory cough is patients who you cannot identify any modifiable treatment factors. And nowadays, a lot of studies are suggesting that chronic hypersensitivity cough is the overriding feature of patients with chronic cough. This is a distinct disorder that is often triggered by low-level thermal, mechanical, or chemical exposure. And this supports our idea from the beginning that sensitization of the neural pathways and higher centers have a major role to play. And nowadays, we're considering more and more treating patients with chronic cough with neuromodulating agents. So in terms of management, even after extensive investigations, including a lot of allergy testing in the allergy clinic, we're not always able to find a treatable trait. However, once we find a treatable trait, we should do sequential therapeutic trials rather than treating the patient with different things all at once, although some patients force you to do that. And we also should consider, in patients we feel that might have hypersensitivity cough, some sort of neuromodulating agent. Even with treatment response, we should be continuing the responding treatments for a prolonged period of time, so that in order to achieve resolution of the neural hypersensitivity. And I will stop there.